stroke is a brain attack, and we always talk what time is the brain, and it requires the faster assessments and investigations, require the acute medical treatments, require the immediate secondary prevention, recognition, management of complications. And coming to the epidemiology of
गुस्सा मेरे पे क्या कर रहे हो उसको?
Is there any connectivity issue?
So, according to the stroke epidemiology, we see that there's a 15 million strokes per year, and out of that, we see the 6 million death and 5 million disability. You know, stroke is a kind of disabling disease. If you not treat on the time, it can cause the disabilities. And we are projected that 8 million death could be occur by 2030, and more than 60% death is happens in almost less than 70 years of age in the young patient also. And this reduction 4% per year, we can lead to the 6 million fewer deaths in next 10 years. If we at least reduce the 4% of reduction less stroke per year, it can cause the 6 million less death in the next 10 years. And stroke is not a disease, it is a kind of different mechanism. There is something called TOAST classification we use in the stroke, where we divide the stroke with the different mechanisms. Like it could be the large vessel disease, it could be the small vessel disease, it could be the cardioembolic, and it could be the because of different hypercoagulable state and the different kinds of undetermined etiology. Usually we see because of the cardiac, like the atrial fibrillation, some valvular disease, with the ventricular thrombus or the cardiogenic emboli, and sometimes we see the aortic embolic, like aortic arch plaque, and then because of the carotid stenosis and the intracranial vessel stenosis also. And sometimes we see because of the small vessel disease, so we divide in the TOAST classification according to 1 to 5. And if we see the etiology by the stroke, the patient who have the large artery disease, large artery disease means patient having the carotid disease beyond that, like antecerebral artery, middle cerebral artery, and the postcerebral artery, they have the different event rate than those who have the small artery disease. And if you see this graph, this the green one is the small vessel disease, which is the lesser chance of recurrence. This is a chance of having the recurrence and that causes the disability. But if you see that this blue line is large vessel disease, large artery disease, which definitely has the more chance of recurrence and it can cause the major stroke, and then in comparison to the small vessel disease. And these are the cardioembolic, which comes between the small vessels and large vessels. So coming to the one case scenario about the 185-year-old females, where she got the left side weakness, and she goes to the hospitals. She has history of hypertension, which she got on AC inhibitors, but there's no other medical issues. And she reached after 7 hours after the onset. There's something called window period in the stroke we use, that is up to the 4.5 hours. Where if the patient comes within the 4 to 4.5 hours, we have some thrombolytic agents we definitely extrapolated from the all cardiac studies and the evidences we take from, and you use the acrylase altiplase for the thrombolysis. Nowadays the tenecteplase also the second thrombolytic agents which are coming for the thrombolysis. And where but this patient which comes after the 4.5 hours, we don't have any options, we just have to give the antithrombotic agents. So what is the right treatment the patient who comes after 7 hours? Then we have to see about the mechanism of the stroke. Usually in our setups in the care hospitals, we have the stroke centers where we use the MRI, because our emergency is just beside the MRI departments. We use the MRI, and if it is beyond the window periods, we usually try to do the CT brain angio to see the vessels conditions, where the carotid and the MC and AC, how the vessels are there. And we usually do the echo also, the bed screening to just see that if there's any LV clot is there, or definitely ECG to see just any AF is there, or any rhythm abnormality is there, and accordingly we start the treatments. To coming to the antithrombotic agents, we see that 20% stroke are recurrents, and it proves in all the kind of individual studies in the time specific meta-analysis or meta-regression estimations, and even the different study shows that over the time of period they have the recurrence chances are more, almost in 20% patients. Now coming to the antiplatelet, where the aspirin, definitely aspirin has been proven for secondary preventions, and clopidogrel and the combination with aspirin also acceptable alternative, and it has been proven with the different trials, that is called MASH trial and SPS3 trials. We see that the effect of antiplatelet therapy definitely is good on non-fatal stroke. It definitely, if you see this Forrester graph, it favors the antiplatelet better than the antiplatelet worsening. In all the category trial where the patient having the previous MI, patient have the acute MI, previous patient have the previous stroke and TIA, acute stroke and other high risk, we see all the patient, all the trials have favored the antiplatelets, and then not giving the antiplatelet. So patient having the prior stroke and try allocated to the receive any antiplatelet agents versus control, we have benefit in reduction of the any vascular events up to the 25%. It's very uh, gratifying. And the benefits of antiplatelet therapy in the reductions, we can see the in the both the fatal non-fatal strokes almost almost 22%, this risk reduction rate is there with a significant, very significant p-value in comparison to the control. This capital trial is very old trial where it has been definitely has been also extrapolated from the cardiac trial only, where they show that clopidogrel is superior to aspirin in preventing in the MI, stroke, and vascular deaths. Uh, there's a match trial where they've studied about the recent ischemic stroke or TIA with the this combinations is superior to the clopidogrel alone in preventing ischemic events. That was the primary aim of that study, and what they found that there is no benefit of this combination versus the clopidogrel. They found, and instead of they found a threefold increase in the major hemorrhages. You can see in this graph is almost both having without any significant p-value with the increase in the major hemorrhages. Now coming to the SPS3 trial, where the same have the patient having the small symptomatic electron infarcts, where this combination is superior to aspirin in preventing. They also studied almost 3,000 patients within 6 months, where they found again this combination is not superior than the just aspirin alone, with a twofold increase in the major hemorrhage. But I want to emphasize that these both trials has the small vessel disease. This MASH trial and SPS trial both has studied with the small, not the large vessel disease. Though in the further slide we discuss about the large vessel disease also. Uh, the stroke risk definitely is high immediately after the TI, and also about the mild ischemic stroke. You can see that at the initial time the risk of stroke recurrence is very high, so that we have to. That's why it's called ABCD square scores in the TI we use, where we find that the initial days they have the higher risk, and we have to act very fast. So this MASH trial again, where they treated the patient within 7 days of event, and they found that and almost 20% of patients within 7 days, and there's no trials done during the acute phase, means acute phase within 24 hours. And all the if we take all the qualifying events with all the factors like age, sex, hypertension, diabetes, previous ischemic strokes, previous TIA, and the previous MI, and angina pectoris, and other cardiac issues, it all favors the combination of aspirin clopidogrel than the placebo with the clopidogrel. This is the trial shows that the patient having large vessel disease and the minor stroke and TI definitely uh, the double antiplatelet therapy is definitely is beneficial. The same says that the stroke is high in the first few days, 2 weeks after TI and minor ischemic stroke, and 5 to 11% stroke over 90 days, and half of the risk occurs in the first 2 to 7 days. And situation is definitely unstable in case to risk of more severe strokes, more likely to have the new thrombus and like to the different consequences. The major clinical trials, again the CHARGE trial, which happened in 2008 and completed in 2013, point which started in 2007, completed in 2018, which again was a combination versus aspirin. And one of the Socrates trials, it started in 2011 and completed in 2016, is the ticagrelor versus aspirin. And the ticagrelor aspirin combinations versus aspirin, which started in 2017, sales trials, which completed in 2020, will just focus on the chance and point trial here. In the chance trials, definitely the combination of drugs which was superior with a survival-free stroke than the aspirin, and the point trial, it was the different results showing the aspirin having uh, patient who has the combination has the lesser events than the aspirin alone. So this in the CHARGE trial, what they use, they loaded with 300 mg and then the 75 mg per day versus placebo over 3 weeks, and the aspirin was common in the both the groups, 75 mg per day. Inclusion was the TIA, which was there for the classical deficient less than 12 24 hours, and ABCD score was 4 and more than 4, with a minor stroke with NHS less than 3. And the 90-day stroke, this done both the trial was done in China, and in the point trial they have given a 600 mg loading dose, and they given up to the 90 days, 3 months. It was 3 weeks, about 3 months, and the aspirin was 75 to 25 mg per day. In here, the TI, they have taken the up to 12 hours, ABC squares 4 and more than 4, and minor stroke 3 and less than 3. And both the trial shows that in the both the in the both the groups, what they found that there is no significant increase in the bleeding. There is no significant p-value in any kind of things. And death also was not significant in both the groups. The bleeding was little bit increased definitely with the patients, but there is not significant in the severe and moderate bleeding. A little bit mild bleeding was there. If we see the absolute differences by time period in a point trial, it definitely in the first month it was very significant. It was significant helping in the preventing the major ischemic events. But if you see the beyond 1 month, in the second and third month, definitely there's a chance of little bit bleeding was there compared to the ischemic events. So it's very kind of we have to balance on the where the bleeding chance more and the thrombotic chance worse. We'll discuss again the next few slides. The dual antiplatelet therapies was aspirin, the minor stroke and TI, where the different meta-analysis were done. The 4 trials comprising of the 21,000 patients, where the aspirin with the P2Y and 2I inhibitors, ticagrelor, and aspirin was placebo. They found the recurrent strokes with significant p-value with the aspirin alone, with the combination having the lesser. The major bleed was definitely higher with the aspirin and the ticagrelor combination. In the minor stroke or high risk TI, short term definitely reduce the risk of recurrent stroke at the expense of the high risk of major bleeds. So as compared to aspirin, short-term dual antiplatelet therapy within 24 hours of high-risk TI and a mild to moderate stroke reduces the risk of recurrent stroke at the expense of the higher risk of major bleeding. So what is the guidelines are there by the ASO that they have told that the ASO recommendations there in the non-cardioembolic minor stroke, the NHS less than 3 with the high-risk TI with the ABC score more than 4 and more than 4 in the past 24 hours. They recommend a 3 weeks double antiplatelet therapy with aspirin and clopidogrel followed by the antiplatelet monotherapy thereafter. In the American Stroke Association and AHA recommendations, where they have the same minor strokes, 3 and less than 3, the non-cardioembolic ischemic stroke and the high risk TI. With the double antiplatelet therapy, aspirin with clopidogrel should be initiated as early as possible within 12 to 24 hours, and at least within 7 days. They're given up to 3 weeks to 3 months. Here they have given up to 3 months, but American guidelines say they can give up to the 3 months. Followed by the single antiplatelet to reduce the risk of recurrent ischemic stroke with the level 1A recommendations. Coming to the clinical guidelines, finally, with the American Heart Association and Stroke Association, patients presenting with the minor non-cardiomyopathic stroke and NHS less than 3 who do not receive any antiplatelet or do not receive the altiplase treatment with double antiplatelet start within 24 hours after symptom onset, because if we thrombolize in the stroke, if we thrombolize patients, we don't start the anti-thrombotic agent for the 24 hours. We wait 24 hours and then we start the antiplatelet, double antiplatelet, depending on the mechanism of the strokes. So if the patient not receives the antiplatelet, we wait for 24 hours and then continue for the 3 weeks, effective in reducing the recurrent strokes for a period up to the 3 months with a grade 1 recommendations. And with the European stroke organizations, there is strong recommendations about the high quality of evidence with the use of 3 weeks of double antiplatelet with aspirin clopidogrel with the non-cardioembolic minor strokes or high risk in the past 24 hours. In the Canadian stroke also best practice, they also have the same conclusion that very high risk TI or minor stroke of non-cardioembolic with NHS 0 to 3 combinations of the aspirin clopidogrel given for the 3 to 4 weeks, followed by the antiplatelet monotherapy with the evidence of level A. So what is the take-home message? Definitely the combination clopidogrel aspirin combination effective combination when initiated as soon as possible after non-cardioembolic mild ischemic stroke and high risk TI when not treating with thrombolysis and thrombectomy. 3 weeks to 4 weeks treatment appears to be enough. Outside this acute and subacute period, the hemorrhage risk is definitely outweighs any benefit in reducing ischemic stroke. Aspirin plus clopidogrel is more effective than aspirin, but less effective than anticoagulations for preventing stroke from atrial fibrillations. Benefits of this combination must be balanced against the hemorrhage risk. So again, I just want to revise that. As I told you that in the stroke we go for the mechanisms. We look for the mechanisms. It is a large vessel disease, large artery vessel disease like aortoembolic or carotid stenosis, or the any major intracranial vessels like intercerebral artery, middle cerebral artery, and posterior artery stenosis. In those cases, we start with the double antiplatelets, the aspirin clopidogrel combinations. Usually, we give up to the 3 month. That what we follow. The second comes to the small vessel disease, where the single antiplatelet is sufficient, except if the patient having the high risk high risk TI is there, like if the ABCD score is 4 and more than 4, there we use up to the at least minimum for 3 weeks, and depending on other regions, we use for 3 months also. Then coming to the cardioembolic, where we see the patient having and definitely have the valvular disease, then definitely the patient require the, and if the patient mechanical valves are there, they require the warfarin, vitamin K antagonist, and the patient who have the non-valvular AF, where definitely the newer anticoagulants like dabigatran and the pexaban and the rivaroxaban is definitely better than this antiplatelet. Yeah, and the fourth is definitely is hypercoagulable states, where patients depending on what the hypercoagulable state is there, and we start the medications. And definitely something called cryptogenic strokes, and something called now is coming the embolic stroke for unknown source, where we do the halters and extended loop records for almost for a month, for 30 days, for 1 week to 1 month, to see, because if we by seeing the nature of infarct in the MRI, we can know that it could be the embolic stroke. But still, the evidence not there to, if we don't have the enough evidence, like if you don't find proximal AF in the Holter or ELR records, we don't need to start the anticoagulation patients. We still go for the antiplatelet. But if in the ELR records, in the Holter record, if found the proximal AF and it's definitely embolic stroke is there, we go for the newer anticoagulants. And then definitely something called cryptogenic stroke, even after the, usually in the mechanism, as I told you before, we do the MRI brains, that's called stroke protocol with different imaging